Malhotra, if I pronounced that properly. Sanchi today is going to talk to us about increasing cases of severe pediatric coccidioidomycosis from 2000 to 2024, description and outcomes at a tertiary care center, and she's from the University of California, Los Angeles.
Thank you so much to the organizers for letting us speak so much about pediatric cocci this meeting. And I've already learned so much even about my presentation from the talks that have already happened and how that would influence our own research. But as a background, the incidence of pediatric cocci has increased threefold over the last 20 years in California, and that's from 1.8 per 100,000 patients to 5.9 per 100,000 patients. There's been prior pediatric case series, but most of them are data from prior to 2013 and a lot from our colleagues at Valley Children, but we just wanted to add to that literature. And prior pediatric case series do describe high rates of treatment, which I know was talked about yesterday, and also higher rates of disseminated disease than is described in the adult population. And then this paper by Dr. Thompson that's always scared me is that there's been increasing fluconazole MICs in vitro being described. And so there's a lot of questions that still remain about pediatric coccidioidomycosis, and I'm not going to be able to answer all of those with my presentation, but at least give you a little bit more data. So I think based on these prior case series, we did want to also look at if our pediatric patients have a higher rate of dissemination or need for treatment. Do the same risk factors such as race or immunocompromised status play a role in pediatric infections? How long are our patients getting treated? What sites of dissemination are most common? And is fluconazole still the best empiric treatment for our severe disease? So we did a single center retrospective observational study at Mattel Children's Hospital at UCLA. We looked for patients age 1 month to 18 years of age with the ICD-10 codes listed here. We also looked for whether they had a positive culture or a positive CF titer. This might be a little bit controversial, but we didn't search if they only had an EIA alone just because our lab we do in-house has a lot of false positive IgMs, and we were hoping we could catch some cases with ICD-10 or confirmatory CF titer, but perhaps we will go back and look at those now. And then we did manual chart abstraction by the authors of our study and did statistical analysis. So we had 104 patients that met the search criteria I just listed out and ended up with 67 included in our analysis, and 70% had uncomplicated pulmonary disease and 30% had disseminated disease. And when looking at these cases by year, this was actually a recent publication just a few weeks ago from the California Department of Health looking at cocci cases and predicted cases in 2024. And you can see that our data matches pretty nicely with the spikes in cases throughout California. And so the epi is a little bit similar in our hospital. When we look at these cases by dissemination or not, the main thing I wanted to highlight here is that while there was a spike of cases in cocci, as we all know, in 2018, there wasn't a real change in disseminated cases that we saw at UCLA during that time, but we saw a whole lot of disseminated cases last year compared to previous, and I'll talk about why that might be. In terms of the demographics of our patients, so our patients with disseminated disease were statistically significantly a little bit older, and then as you can see, all of our patients who are Black or African American had disseminated disease, which is consistent with prior data. And then looking at where our patients are coming from, not too surprisingly, a lot of referrals from Kern County, a lot from Los Angeles itself, and this matches pretty well with California data from where most cases come from. Granted, this is just looking at the zip codes of where they live, so if a patient did acquire their infection from somewhere else, that's not perfectly captured by this map, but still gives us a good idea. In terms of their symptoms prior to presentation, not too surprisingly, patients with pulmonary disease were more likely to have cough, chest pain, and then patients with disseminated disease were more likely to have joint or bone pain, CNS symptoms, skin lesions, or cervical lymphadenopathy. Some of the ones that weren't statistically significant, but I think are meaningful when you look at it, 22% of our patients with pulmonary disease did have erythema nodosum. Only one patient with disseminated disease did. And I'm not sure why that's not statistically significant, but I think is. And then similarly, with respiratory failure, we saw a big difference between pulmonary and disseminated disease. And then we also looked at our cases based on the recent classification schema that was published by these collaborators. And the main thing I wanted to highlight here is in our pediatric patients, we really don't see a lot of cavitary disease. 64% of our patients had state category 2 infection, so had parenchymal disease or lymphadenopathy, but very few had simple cavitation and none had fibrocavitary lung disease. And then in terms of our disseminated cases, which I'll go into a little bit more, but we had quite a distribution in terms of our CNS cases, which categories they fell into. And so looking at sites of dissemination, a high percentage did have both MSK involvement and CNS involvement, and then a little bit less for skin, lymphadenopathy, or organ involvement. And then in terms of what kind of testing was done at our hospital, so 84% of our patients did get an EIA, and as we all know, it's quite sensitive, and 100% of them were positive. Only about 80% got an immunodiffusion, but also had a high rate of positivity. And then most patients did get a serum complement fixation, but was not always positive. About half of our patients had either culture or path performed to look for cocci, and about half of those were positive by either culture or path. There wasn't any significant difference when we looked for disseminated disease for peak CF titer at diagnosis between 1 to 16 or greater than 1 to 16. And I think this was talked about in the pediatric case series yesterday. But for us, we think because a lot of our patients are coming from Kern County, they might have labs from Quest, or we send all of our labs to UC Davis. So there's a lot of interlab variability, as we all know. So it's hard for us to make a really firm conclusion about whether or not that's significant. And then looking at the 9 samples that we did that had susceptibility testing, as you can see, most of them are from 2024. But the main thing I wanted to show you here is half of our cases in 2024 had an elevated MIC to fluconazole. And those 3 cases with the elevated MIC were patients with disseminated infection with either bone or CNS involvement, so something of concern. The other thing I thought was interesting is in the literature, the MIC90 for cocci against ISABU is 0.5, and we did have 2 cases with elevated ISABU MIC as well, but POSA MIC was pretty reliably low. And so overall, 88% of our patients were started on a medication. Granted, a lot of these were referrals and potentially were started already from their pediatrician at an outside hospital, but and 85% of them received fluconazole initially. 40% of all of our patients did require a switch or an additional medication, and most of them had disseminated disease, and patients with disseminated disease had a significantly higher likelihood of being either switched or requiring multiple medications. Not surprisingly, patients with disseminated disease were treated on average for 15 months longer than those with pulmonary disease, but as you can see, those with pulmonary disease were still treated for a pretty long amount of time of 8 months. And looking back, especially I think pre the more recent guidelines, a lot of people were treating until CF was negative, but that practice has slowly been changing. And then 10 of our patients did get concurrent interferon gamma, and 5 got concurrent dupilumab per our AI colleagues. And this is excluding patients who are still on lifelong treatment or are still on ongoing treatment for 2024, so that difference in treatment duration is likely a lot longer. And then in terms of what they got for treatment, so like I said, most patients were started on fluconazole, but 11 patients did have to be switched from fluconazole, and posaconazole was the second most common final treatment duration. And then the main thing I also wanted to highlight is of our patients with CNS infection, which was 9 of them, only 1 of them was managed on fluconazole as their lifelong azole therapy. The other 8 had to be switched for various reasons. And then looking at our patient outcomes, we had 3 deaths due to infection. 2 were from cocci-meningitis, and 1 was from a severe pulmonary case with ARDS. But there's no difference in mortality because of those low numbers. Interestingly, none of our patients with disseminated disease were lost to follow-up, compared to 30% of our patients with pulmonary disease who were lost to follow-up potentially went back to their primary care provider. We didn't see a significant difference in resolved infection between disseminated and pulmonary disease, but those with disseminated disease were, of course, more likely to still be on treatment. And so overall, this is just a retrospective case series. It's just a single center, so I can't make a lot of conclusions from this data, but we did see a higher proportion of cases with disseminated cocci compared to adult data. This is perhaps a sampling bias, but it's similar to what was described in prior pediatric case series, so I still think it's a concerning finding. As I described, we saw increasing rates of disseminated disease in 2024. This might be a referral bias. I know there's changes in staffing at other children's hospitals, so it potentially could reflect that, but still something that, is concerning to us as providers. And then as was discussed yesterday, a lot of pediatric patients are started on treatment for cocci, and whether that's necessary or not, I think still remains to be seen. And then as I mentioned, half of our isolates in 2024, maybe I shouldn't say resistant, but had elevated MIC to fluconazole. And most of our cases of disseminated disease required a switch or an additional in antifungals. And so there's just an increasing concern about fluconazole refractory or resistant disease, particularly if you have a severe disseminated presentation, whether that should still be first line. And then there might be some opportunities to decrease treatment initiation or duration for uncomplicated pulmonary disease. And I think that's just some education that needs to be done with our local pediatricians and our ID providers too. Luckily, we did see a very low rate of relapse in our cohort. And then, as I mentioned, patients with disseminated disease do require longer treatment and are more likely to still be on therapy at their last follow-up. So these are our acknowledgements. Thank you to everyone here who's helped care for these patients.
Thank you very much. Does anybody have any questions?
Hi, Wasim Balan from Phoenix Children's. Do you have any of your patients who are on combination therapy? And if you looked at specifically how they compare to the rest of the patients?
Yeah, we had a lot of patients on combination with AmBisome upfront, but none that have remained on combination kind of towards the end of therapy. And of course, a lot of those are patients with bony disease, disseminated disease.
So usually AmBisome and an azole?
Yeah.
Have you ever had the combination of echinocandin with an azole?
I think there was only 1 or 2 patients that got an echinocandin, and I think one of them had concurrent candida infection, so we don't really use that combo, yeah.
That was really nicely systematically done. One thing I would wonder if you might do is, again, you hinted at this as a referral center and a hospital-based study to really answer the question of, are we seeing increased disseminated disease is a little challenge. Yeah. You had the county level data, but I think that was aggregated across your 5 years. If you were to look over time, as I don't actually know how to time it, but as most of us know, as pediatric providers in Southern California, the unavailability of services at Valley Children's has really shifted presentations, and you could probably get a little bit more at that. If they have population data from there, you'd have a sense of, okay, it's just a presentation and pseudo epiphenomena rather than a real increase in disseminated disease.
Yeah, I totally agree. That's what I was trying to hint at, those changes at Valley Children's. And so I think maybe if we pilot our data, we could really show that a little bit better, like you said. Thank you.
It's curious, the azole MIC phenomenon, when we think antibacterial resistance in bacteria, because we're constantly exposing ourselves and selecting for that. How is that happening in the environment? Maybe it is in the agricultural regions, the Central Valley is a fantastic agricultural area. If they're using azoles, obviously not fluconazole, but there's probably antifungals they're using. It'd be interesting to see if your high MICs map to those regions versus other regions, because then we can try to help them find other things that don't drive resistance. And then is that increasing resistance somehow tied to disseminated disease would be an interesting, association to explore, but it doesn't make sense to me, but
yeah,
maybe there's something there.
No, that's a great comment. I was just going to say Dr. Thompson could probably talk about that better, so I don't know if you have a comment.
This is something we've thought about for a long time. I think that we need a lot of work done still for PKPD, for cocci. John, I agree with John. We have these MICs, which are mycelial phased. I don't know what that means for spheral endospore. Sporothrix, when you grow in yeast versus mycelia, are very different. So it's hard to say they correlate. But the mouse model data presented in Davis at the U19 meeting just a few weeks ago looks like it does correlate pretty well, the mycelia MICs with their outcomes in mice, not people. And then back to the resistance question for the environmental azoles. So if we stole the data from Aspergillus for Netherlands and UK, so that's mostly tebuconazole and another azole, but they should cause mold active azole resistance, not just flu. So I think that's very difficult to explain. But then bigger picture wise, olorifim and fosmanogepix we're very excited about. But ipflufenaquin, which is an analog, same pathway as olorifim, and aminopyrafin, which is the same pathway as fosmanogepix, were approved by the EPA for use in agricultural processes. That's been a big problem. The CDC and EPA have put together a consensus statement. We have an article coming out in the New England Journal sometime soon that talks about this, but they've broke down all these silos to show like EPA shouldn't do this without the USDA, CDC, FDA, et cetera. So I think that they've all gotten on the same page.
Okay.
Globally, they have not though. So I think this is still something that needs a lot of attention for not just cocci, but just global mycotic infections. We've learned that from chickens and antibiotics, but we've not figured this out for mycology quite yet, I think.
Do you see that difference too between imidis and Posadii? Because I think there's been a lot of talk, between Arizona and California, and I've heard in Arizona there's still a lot of success with fluconazole, and I wonder if that's...
That may be more physician sociologic practice.
Okay.
It's like, do you believe, I have a hard time saying, why would PKPD matter for every other infectious disease except cocci? To me, that doesn't make much sense. But I do think we still have a lot of work to do. And this is going to require coordinated effort for people that can put these isolates into the SE phase, and then people with a lot of experience like the fungus testing lab to do susceptibility testing and figure out the different parameters, the dosing, the number of isolates needed. All those things be done in high volume with multiple species in triplicate. Like that's a huge undertaking and is R01 level funding to do that. I don't know that there's difference in susceptibility. The fungus testing lab has pulled all their isolates that have been identified to species level. There's not big differences. We have seen temporal differences with the species susceptibility. So during COVID, the resistance went way up. And I don't know if people were just bored and checking more susceptibilities to not think about COVID. And then we've seen it come back down since. And the denominator has been roughly the same. That was presented at ID Week last year. But I think until we need a lot of environmental isolates to look at this. Is this a pretreatment effect as well? I don't know. I have a lot of questions, but very few answers. So,
Thank you
And
very much,
so-
Dr. Malhotra.
So
I'm
just a
sorry.
follow-up on Dr. Thompson's comment in terms of the MICs. We're actually, a year ago, we took a decision that anytime we're culturing cocci and from a patient, we're sending it for susceptibility testing, mostly to compile that data. And we're seeing kind of a similar pattern. So I don't think there's a difference, at least anecdotally, so far from the table you showed, between what you're seeing in California and what we're seeing in children.
Okay.
But we don't have, all the data. We're hoping that with time, since we're just any positive culture, we're sending it for susceptibility testing, maybe we'll be able to look at that too.
Yeah, that would be great if we can group our
Thank you.
cohorts. Yeah.
Sounds like next year we need to have a special session on antifungal susceptibility and changes in it. Thank you very much, Dr. Malhotra. Our next speaker is Sarah Zhang.